Our talk this evening. This is on our theme. Our theme for this week is adult medicine, and we are going to be focusing on diabetes. And I always find it interesting. I think we have a preponderance to have vast amounts of meetings around HIV and TB, and yet we're actually finding that diabetes is keeping us much busier in our outpatients departments these days than HIV. So I'd like to introduce Professor Joel Dave. He's the head of the Division of Endocrinology at Groote Schuur Hospital at UCT, and he's actively engaged in both the undergraduate and postgraduate education in general medicine and endocrinology. His research focuses on the intersection of infectious diseases and endocrinology, strategies to simplify diabetes treatment, and methods to prevent lower limb amputations in people with diabetes. And some of you might not be aware, but we've been having some challenges with some of the pen sets within the public sector, and very excitedly, some of those have been replaced with different products. But yeah, the world of insulin management is also a rapidly evolving field. So we're very happy to have somebody that can give us some insights on better use of insulin in our patients in our rural resource restrained settings. Prof. Joel, I'm going to hand over to you.
Thank you very much, and thanks very much for the invitation to talk. I'm just going to share my screen. Can you see the...
Yes, perfectly. Thank you.
Okay. So thanks very much for the invitation. And I liked your introduction because, there's no doubt now that non-communicable diseases have exceeded communicable diseases. And in 2015, I think it was the first time, but it was one of the first times where deaths from non-communicable diseases exceeded deaths from HIV, TB, and malaria all put together. Because if you spend time in the wards in South Africa, and as you mentioned, rural areas, there's loads of HIV and TB, and it's very easy to get the impression that that is what is predominant in our society. But unfortunately, diabetes is the number one killer of women in South Africa, and it's number 2 behind TB in South Africa. And it's certainly the number 1 killer in the Western Cape, in women, and I think also in men. So there's no doubt that diabetes has a very high morbidity and mortality. And it's quite sad because it's all completely preventable. The oldest person living with type 1 diabetes at the moment in the world is a person called Libby Leshansky. She's in America. And when I watched the YouTube video, it's very easy to quickly hear that accent. And she's actually an ex-South African, was a doctor. She's married, she's got kids, she's got grandkids, she's got great-grandkids, and she's 92 years old. And she was diagnosed when she was 11. So she's been on insulin for 81 years, and she's not on the insulin that we know. She didn't start off on the insulin that we know. She started off with when insulin was injected through thick needles. It was a syrupy conglomerate that gave you infections and abscesses and allergic reactions. And despite all of this, she has managed to remain complication-free, led an extremely productive life, and is very happy at the ripe old age of 92. So it can be done. It is possible for us to keep all our patients in good health for many years if you have diabetes. And so I'm going to introduce you to Mr. X. He's a 48-year-old man, a smoker, has type 2 diabetes for the past 6 years and also hypertension. He has a family history of a father who had a myocardial infarct at 52 years old. He does do some gym once or twice a week. He does weights, and he's compliant on his medication and his diet. So I just want to minimize a few things here quickly. And this is his medication. So this is what we have access to in the public sector, metformin. He's on maximum dose. He's on glimepiride, maximum dose. I know sometimes people extend it to 6 milligrams. He's on a statin and he's on amlodipine for his blood pressure. And this was his examination. He's obese. He's got acanthosis nigricans, suggesting insulin resistance. And he's got some diabetic complications already. He's got non-proliferative retinopathy. He's got a peripheral neuropathy. And he's got borderline control of his blood pressure. And the rest of the clinical examination was normal. And if you have a look at his blood tests, he's got an HbA1c of 8.8, remembering that he's compliant on his medication and he's on maximum dose of oral medication. And he already has microalbuminuria and an abnormal creatinine. So he's actually, unfortunately, in trouble. And if we have a look at his historic results, he's never had an HbA1c less than 8.5%. And at diagnosis, his HbA1c was 9.4%. So literally for the last 6 years, he's had a HbA1c that hasn't been at control. And you can see, unfortunately, it's progressed over the last 4 years. His creatinine's now, it used to be 72. It's now normal. And at that stage, in 2022, he had microalbuminuria. So I just want to take a step back and have a look at what we've learned from our landmark study, the UKPDS, the United Kingdom Prevention of Diabetes Complication Study. This was the landmark study in people with type 2 diabetes. They've now, and I'm going to show you their 40-year data, and it's never going to be repeated. And the importance of this study is that, yes, it's a landmark study, but it's also literally the only study we have in people newly diagnosed with diabetes. So it's basically primary prevention study. And so number one, if we have a look at glycemic control, this was the first time it was showed that if we controlled glycemia, we could decrease microvascular complications. And then in the extension of the UKPDS, we eventually showed we could decrease macrovascular complications after about 10 years of follow-up. And this is where we got that magical number of HbA1c less than 7%, because here it was shown that people who had an A1C of less than 7% had maximum benefit in the risk reduction. It also showed us 3 other important things. Number one, that actually we get benefit for every 1% in HbA1c reduction. So very important that we never give up on our patients. So because many of us will have patients whose A1Cs are 15, 16. I had a patient a few years ago where it was 23, and then recently it was 19. And it's very easy to throw your arms in the air and say, look, there's nothing I can do. But if you manage to actually just get through to your patient and your patient can reduce their A1C by at least 1%, then your interaction with that patient has actually been beneficial. So for every 1% reduction in A1C, there's benefit. Another thing it showed was that monotherapy in people with type 2 diabetes fails. So it's never a treat and forget. It's unfortunately a treat and follow up and monitor, because generally as someone with type 2 diabetes progresses, they're going to need more and more medication and are likely ultimately to land up on insulin. And another very important concept it showed, and I suppose I shouldn't have put it in such a small block, what it showed is something called the legacy effect. So in the initial study, the intensive group had a much lower A1C reduction than the conventional group. And then at the end of the study, they were all followed up again. And those in the active treatment group, in their A1C actually worsened. The intensively treatment group, they actually worsened slightly. And the usual treatment group actually improved slightly, such that for the next 10 to 15 years, the A1Cs were the same. Yet the intensively treated group years down the line, and I'm going to show you later 20, 30, 40-year data, they still had a much better outcome in the form of reduced microvascular events and reduced macrovascular events. And so it's this legacy of any period of good diabetes control translates years down the line to ongoing benefit. So very important, number one, that we lower the A1C of our patients. Number two, we do it quickly so that this legacy effect, that we try and keep them as controlled as possible for as long as possible, so that they reap the benefits of this years down the line. The fact that monotherapy fails basically shows the natural history of type 2 diabetes, which is unfortunately that it gets worse. Progression, and it gets worse. And you can see here that they've shown sort of like as we get older and as we go along, we tend to gain more weight. Because we gain more weight, we tend to get more and more insulin resistant. And you can see initially our beta cells are able to respond, okay, in producing insulin and keeping us normoglycemic. Then it plateaus, but then there comes a time, and it's different for different people, where they start losing beta cell mass, until eventually many will actually need insulin to control their diabetes. And it's very important to recognize this transition, because nothing else is going to get these people under control. This is the 24-year follow-up data, just to show you that this is the intensively treated group and the conventionally treated group. And if you have a look across any diabetes-related endpoint, microvascular disease or myocardial infarction, then the red group, the intensively treated group, was below the conventional group. And so for some, it was up to 40 years. And so there's massive benefit in early control from when you're diagnosed. And this translates for many years better reduction in diabetes complications. Unfortunately, it's very, very difficult to get patients to this magical target of 7%. And we all know that. We can see it in our clinics. And I don't think we must feel bad, because if you have a look at the literature from around the world, it basically shows that 2/3 of all patients with diabetes, they have an A1C greater than 7%. So in many countries where they have access, they still can't get their patients to less than 7%. And you can see here, unfortunately, at least 1 in 10, 1 in 9 will still have an A1C of greater than 10%. And so the question we always have to ask is why? Why is it that we cannot get our patients to this magical target of less than 7, or at least as close to 7 as possible? Many of us sit with patients whose A1Cs are over 9%, over 10%. And just another slide to show you that early diabetes control, we learned from the UK PDS this legacy effect, but this is another study basically to show that early diabetes control is very important. So what they did in this study, they compared people with different A1Cs to a group who managed to control their A1C to less than 6.5% in the first year. Okay, so this was people in the first year who had this A1C compared to someone who was very, very well controlled. And this is what they showed, that from microvascular events, macrovascular events, and death, that those with the worst control in the first year of being diagnosed, they were far worse off down the line than someone who within the first year was controlled to an A1C of less than 6.5%. And you can see it's completely dependent on the A1C. If you have a look at those at the end of the first year after being diagnosed, you can see that they had much greater risk than those who had control in the first year. another thing over here, they showed that if your treatment wasn't escalated within the first year of being diagnosed, the chances of getting you to target later on down the line, just apologies. I'm sorry, I just got an urgent call. Just hold 1 second. Okay, so the chances of getting you to target were much less. So they can showed you here that if you weren't controlled within the 12 to 24 months after you failed your initial therapy, there was a 22% lower chance of getting you to target. And if you weren't at target within the first 2 to 3 years, then there was a 28% chance of not getting you to target. And they compared it to people who actually were at target within the first year after your initial therapy failed. So what this shows us is that we really have to be aggressive in our management. We have to treat early. We have to try to get to target, and we have to monitor so that when we see that our initial drug, let's say often it's metformin, is failing, we really need to come in with another drug quickly and not wait and wait and wait for as long as possible to delay getting patients onto another drug. And this guideline-driven escalation of care, where you add metformin, in the old days, you used to start with lifestyle and diet and lifestyle. Then you used to go into metformin, then a sulfonylurea, then an insulin. And then insulin eventually. It shows that if you go that way, it can take 7 to 10 to 15 years before you actually get onto insulin, which is something that can definitely get you to control. So very important to recognize this and to escalate early. And there's a whole, this is the consequences of basically not getting our patients to control early. And so it shows you here, this is a summary of some of the data, that every 1 year of poor glycemic control in people with type 2 diabetes increases your risk of this by those numbers, and also increases your risk of macrovascular disease. So basically, it's pushing us all to really try and get our patients under control early. And it's this concept of clinical inertia, and it affects all of us. And we often get asked by the patients, doctor, please give me 3 more months. I promise you I'll eat better, I'll lose weight, I'll exercise. Don't give me more medication. Don't give me insulin now. Let's just wait. And it's this clinical inertia, unfortunately, that puts many of our patients at risk. And there's many reasons for that. I'm just going to show you the 3 main ones, are obviously related to the healthcare system, which I suppose us working in the public sector could complain a lot about. Then there's also clinician-related factors, and then patient-related factors. Now, I'm going to expand this a bit, and it's going to look a little bit complicated, but just to show you that there are multiple reasons why a clinician, defers escalating care in someone with diabetes. The common ones are, number one, overbooked clinics. We're just very busy. And when you're going to escalate care, and especially starting someone on insulin, that's a lot more time that's required in the consultation. We don't really have ready access across the platform to diabetes educators. We're worried that we're going to harm our patients and there's going to be hypoglycemia. So there's lots of problems. And then there's healthcare problems where we can't follow up the patients, and we don't have a team. And then there's patient-related factors. So many factors that actually, unfortunately, push us towards clinical inertia. But I think it's very important that we recognize this and that we try our best to prevent it. Now, some of the best ways to prevent it is empowering ourselves to know all the treatment options that are available to us. and then getting experience and confidence in working with those so that we are able to confidently escalate care early in someone with diabetes where we see that, they're really not getting to target quickly. It's also often possible to start someone on insulin, get them under control, and then to withdraw and change them back onto oral medications. So there's a number of ways that someone can get our patients to target early. Just want to show you that over the last few decades, there's actually been an explosion in the number of drugs now available to us to manage our patients with diabetes. Unfortunately, in the public sector, we only have access to sulfonylureas and metformin, and up to recently, human insulin. All the rest, although we are fighting to try and get access to them, at the moment, we don't have access to many of these drug classes. Needless to say, it is possible to get our patients to targets safely with a sulfonylurea, metformin, and human insulin. And I don't know how old people are on this call, but in my day, because I'm now old, we were taught that type 2 diabetes was the result of something going wrong with the beta cells and insulin resistance, which was usually given to us by weight. So there were two main pathophysiologic processes. And then about I think 10 years ago, as more pathways became known, that someone called it the ominous octet and showed that there were 8 pathophysiologic processes. Now it's been expanded to the egregious 11. So there's at least 11 pathophysiologic processes that put our patients at risk of developing type 2 diabetes. One of them is potentially a beta cell problem. Another one is weight gain and insulin resistance, but there are multiple other inputs from many other organ systems. And luckily now, we have at our disposal, but not in the public sector, we're going to come to that, drugs that can actually target almost all of these pathophysiologic processes. So when you have a look at algorithms of care from guidelines, and they mention individualized care, it is possible in many scenarios to actually now individualize care, depending on what we think the main pathophysiologic process is in our patient. Another thing I want the concept is that not every person should we be trying to get to an HbA1c of less than 7%. Unfortunately, hypoglycemia is dangerous. We are meant to try and avoid hypoglycemia at all costs. And so there are some people who could tolerate periods of hypoglycemia. Unfortunately, there's others that cannot tolerate periods of hypoglycemia. So it's very important that the patient in front of you, you assess them according to these criteria. I've put over here, this is from the South African Endocrine Society, and this is from the American Diabetes Association, and that you use some of these criteria such as disease duration, the life expectancy of the patient, if they have associated comorbidities, where they've got already established complications, the attitude of the patient, and the resources and support of the patient, and that you come up with an individualized target for that patient. So, for example, this 92-year-old Libby Lashansky that I mentioned to you, we wouldn't try and get her HbA1c to less than 6.5%, because that would prevent complications over the next 20, 30, 40 years. She's 92 years old. It's very important that we don't cause a problem in her today. What would that problem be? Hypoglycemia. So with Libby Lashansky, controlling her to an HbA1c of 7.5 or even 8 might be much better, because we got a very low risk of going low. And, unless she's going to live to 120, 130, 140, the short little bits of hyperglycemia aren't actually going to cause long-term consequences in her. So I hope you all get the concept of having to individualize the HbA1c target in the patient in front of you. Just to show you here, this is some data drawn out of a database here in the Western Cape, basically just showing you in the various districts the percentage of people who have an A1C greater than 10% and who are not on insulin. Okay, and you can see here, like literally half of them, half of all the diabetics in all these areas have an A1C greater than 10% and they're not on insulin. Just basically showing severe clinical inertia, therapeutic inertia, because with an HbA1c greater than 10%, every single person should actually be on insulin. So very important that we tackle this. And hence my decision tonight just to talk on clinical inertia and to overcome it. So let's get on to then how we're going to initiate insulin safely in people with type 2 diabetes and how we're going to do this. This is an algorithm from the South African Endocrine Society guidelines in 2017. They are currently being updated, but they're probably not going to change significantly, especially when it comes to insulin. And so whilst they suggest monotherapy here with metformin as initiating, I just want you to see over here, insulin is an option. It's an option for initiating. It's an option for coming in second. It's an option for coming in third. And it's an option for intensifying. Okay, so at all times, insulin actually is an option to you to use in your patient. Many times we elect not to use insulin up front because our patients aren't very poorly controlled. Number one, they don't want to inject. And it's a lot more complicated. It's a lot more risky because the patient has a risk of developing hypoglycemia, much greater risk than when they're on metformin or metformin and glimepiride. So we often choose, when our patients aren't in danger, to rather try oral therapy first before we go into injectables. But there are a few clinical scenarios where we may decide to start with insulin in someone with type 2 diabetes. And this is some criteria that you should use to consider as showing that you could start insulin as first-line therapy. So number one, if your patient is catabolic, so insulin is anabolic. All of you will know that when you start your patients on insulin, they all complain of weight gain. It's anabolic. It makes us gain weight. And so when we are insulinopenic, our patients lose weight. So if you have someone with type 2 diabetes losing weight, that might be a sign that they're now insulinopenic and actually need insulin. Certainly if their fasting plasma glucose is very high, greater than 14, their random glucose very high, greater than 16.7, HbA1c greater than 11, or if in fact they've got ketones in the urine or have ketoacidosis, it might be much better to start your patient with insulin, and often we can then stop insulin at a later stage and get them onto orals. And just to say, these numbers are not cast in stone. You know, so if you have a patient who's catabolic and their fasting sugar is 11 and their A1C is 10, you still are able to make the choice together with your patient to say, look, let's start you on insulin. Let's get you under control. Let's do it quickly. And then once you're under control, we can then see whether we can actually wean you off insulin and back onto oral therapy. Just to show you the various insulins that we have access to. Okay, so the old human insulins that up until now that we've been using, such as NPH, which is protophane, and the regular human insulin, which is ActRapid. Those have been basically our go-to insulins. Okay, just to show you that ActRapid it does act quite fast after a meal, but it has quite a long tail. Okay, so your meal and your gastric emptying probably ends here, but your rapid-acting insulin with ActRapid actually is prolonged. So there are some people, unfortunately, that have hypoglycemic episodes over here. The other thing with our protophane, you can see here, it unfortunately has a peak. So when we ask our patients to give their insulin at 10 o'clock at night, basically at like 2 to 4 in the morning, this insulin is potentially peaking. And so with NPH insulin, protophane insulin, we unfortunately have a greater risk of developing nocturnal hypoglycemia. And so that's where, especially in the old days, all patients were told to have a snack before bed. So they give their insulin at 10 o'clock, they have a snack and they go to sleep. And that snack was to basically to counteract this peak of protophane. These two are now out. And we have new kids on the block, and those are the insulin analogs. So the one insulin analog that the rapid acting that we have access to is a Pedra. Just want you to notice here that a Pedra acts faster than ActRapid, and its tail is much shorter. Okay, so it's a lot more approximated to the meal than ActRapid is. And so the risks associated with a Pedra are far lower than the risks associated with the ActRapid. The other thing, you can see that because its onset of action is so quick, you don't have to take this insulin quite a long time before you have a meal. We recommend patients take it 5 minutes before, but if they can't, then they can take it as they're eating. Remember, with ActRapid, we used to recommend that patients took it 15 to 20 to 30 minutes before they ate, and then they ate, hoping that it would already be peaking by the time they ate. So the change now that we're going to be experiencing of ActRapid to a Pedra is actually a much better change. It's much safer for our patients, and from a quality of life point of view, it's much better because our patients can, I don't know about any of you on the call, but I don't know roughly when I'm going to eat. And so knowing that I'm going to eat in 30 minutes, 15 minutes, I don't know. So the timing of giving ActRapid, I think, was always not really done correctly. Whereas now with a Pedra, when your meal's on the table, you can inject, you can monitor your sugar, decide how much insulin you're going to give, and you can inject. Okay, the next two, I've already mentioned protophane. The insulin that's going to replace protophane is optesulin. Okay, optesulin is insulin glargine. It's what I wanted to show you with the protophane is you can see it doesn't quite last 24 hours. It lasts about 16 to 18 hours. So there were periods of the day where our patients weren't actually covered by long-acting insulin. The optesulin, there's a few things to note. Number one, although it has a little bit of a peak, it's much less than the protophane. And so the chances of having nocturnal hypoglycemia with optesulin are far less, than with NPH. So that optesulin actually is a much safer insulin. And you can see that most of the time, it's actually got a 24-hour action. And so generally, because it lasts longer, we are able to give a little bit less. And so I'm going to go through it later in the talk, but generally when we change our patients from protophane to optesulin, what they recommend is that we reduce the dose by 20%, only because the optesulin is much longer acting. Okay, the changing from ActRapid to a Pedra, it's unit for unit, and it's likely to be much safer because it's much closer approximation to the meal. And so I'm very happy that we now are able to change to these insulin analogs because for our patients, it's actually much safer. And for us as doctors, as clinicians initiating insulin, it actually should give us a little bit more confidence because the chances of our patients going hypoglycemic are far less. Obviously, whenever you give insulin, there's a risk, but it's far less risk with the insulin analogs than with the human insulin. Okay, I hope this isn't too complicated. I just want to focus you over here. These are the three main ways of giving insulin, the three main regimens. The first way is a basal insulin. So that's basically at 10 o'clock at night. Your patient will give a single injection of, it used to be protophane, but now it will be optosulin. So that's the one option. The other option, and I haven't quite put it in this talk, but I'm going to mention it, is giving a premix. So the premix that we've had access to now is actrophane, okay? But it's going to be replaced by Novamix. And Novamix is going to behave exactly the same as the Apidra and the optosulin because it's an insulin analog. It's much safer. It's the rapid component of the Novamix is much closely approximated to meal, so you have a much lower risk of having hypoglycemia, and it's going to be a unit for unit change. So if your patient is on 20 units of actrophane in the morning and 10 units of actrophane before supper, then you'll change them to Novamix, 20 units in the morning before breakfast and 10 units before supper. So it's the same, and it's likely to be a lot safer for your patients. The next one, and which we really don't encourage in people with type 2 diabetes, it's mainly reserved for people with type 1 diabetes, and it can be used in people with type 2 diabetes who are quite insulinopenic, but who are quite empowered and quite insightful and quite motivated to get good diabetes control, because this is our most intensive insulin regimen where we try and mimic normal physiology. So what we do is we give a short-acting insulin before breakfast, before lunch, and before supper, and then a long-acting insulin at 10 o'clock at night. Okay, what this also entails, though, is that the patient monitors before breakfast, monitors before lunch, monitors before supper, and monitors at 10 o'clock at night. So that's basically for this patient a minimum of 8 needle sticks a day, which not every patient is happy doing, and not every patient is able to do it. Okay, so those are the three main regimens. And so when you're having a look at these three regimens, which regimen, should we use to initiate in our insulin in people with type 2 diabetes? Now, that was answered by this study that was published in the New England Journal of Medicine now 19 years ago. And so they asked that exact question. So they had a look at basal insulin, prandial insulin, so the basal bolus, or biphasic insulin, that premix that I showed you. And there was a 1-year study and a 3-year study. I'm presenting to you the 3-year data because they're basically exactly the same as the 1-year data. And if you focus over here for hemoglobin A1C, you can see that all three regimens, at the end of 3 years, they basically gave you the same A1C. Okay, initially, the basal bolus regimen gave a slightly better A1C, but in time, you could see that they were all basically equal. But if you compare the risk of hypoglycemia, and this is more than mild hypoglycemia, you can see that the basal bolus gave the most risk, then the premix, and the basal insulin gave the least hypoglycemia. And so you got the same A1C for less hypoglycemia. And that's why the best way to start insulin in someone with type 2 diabetes is with a basal insulin, a single injection of insulin at 10 o'clock at night. Okay, another thing just to show you, I mentioned I mentioned, and to motivate why we should just be using a basal insulin. I mentioned to you how many people in the public sector have in the Western Cape have an A1C greater than 10%. And if you have a look at that A1C, this is the contribution. So to the A1C, your contribution is from your fasting glucose and your postprandial glucose. But you can see that the higher the A1C, the greater the contribution from your fasting glucose. It's only when you start getting lower down towards the magical number of 7 that the postprandial glucose becomes very important. And so for all of us, when we're going to initiate our patients on insulin, very important that we adopt the safest route, which the 4T study showed was basal insulin. And we use that basal insulin to target our fasting glucose. Okay, so 2 major areas that we can intervene in, especially patients with A1Cs above 9 or 10, to try and get them towards this target in a safe manner. And just to show you, there's this whole thing called fix the fasting glucose first. And I just want to show you, this is a profile of someone who's got normoglycemia. This is someone who's type 2 diabetic. You can see sugars as high as 20. It looks like a complete mess. Let's target the fasting glucose only, and look what happens. You lower the fasting glucose, only that, everything else comes into target. So very important to target that fasting glucose. So with the patient, let's see what happens. So you start with bedtime, either Protophane, or now we have access to Optosulin, and you can choose. 6 to 10 units is recommended, but sometimes in a patient who is really nervous, might live alone, fearful of injecting, you can start with 2 units. It doesn't matter. The first thing is to try and get the patient confident with injecting, and then you can slowly titrate up. If your patient is empowered, has access, has people staying with them, then starting with anywhere between 6 and 10 units of insulin is fine at night, at 10 o'clock at night. And you slowly target the fasting glucose, and that fasting glucose is going to be a target that you have individualized for this patient. So if you're trying to get your patient to an HbA1c of 6.5, then you would target a fasting glucose of somewhere between 4 and 7. But if you've decided to target an A1C of 8, then you might be happy with a fasting glucose of somewhere between 8 and 10. Okay, so very important you start early. If anyone can learn a message from tonight's talk, please, especially in patients who have an A1C greater than 10, please start insulin. Very important that we try and get all of those patients to under 10. And then generally, when we add this long-acting insulin or this NPH, this basal insulin, we keep them on metformin and glimepiride. So you don't stop it, you keep them on it. So it's additive therapy. Okay. Then you check the fasting plasma glucose daily. If it's at the target, that's great. And then you ask your patient to add up their things every 3 days. And if it's not at target, then you can slowly increase the insulin by 1 or 2 units, monitor for the next 3 days. If it's not at target, increase by another 1 to 2 units, monitor for the next 3 days, slowly until you get to your target. And vice versa, if it's below your target, you can actually decrease. So this way, it's very unlikely for your patient to get into any trouble. I'm just going to okay. I'm just going to stay one slide on intensifying insulin. And that means that once your basal insulin you find is not working, you've got your patient to a fasting glucose target, they're compliant, you're happy with their diet, but their A1C is like 9, and you want to get them to 7 or 7.5, then you may need to intensify. And the next best way of intensifying in people with type 2 diabetes is by putting them on a premix insulin. So that means you would stop the long-acting insulin and you would transfer them onto a premix insulin. It used to be Actrophane. It's now Novamix. Okay? You would continue the metformin, and this is the time now when you intensify insulin that you stop the glimepiride. We try and always keep them on metformin because most of our patients are obese. Most of them have an element of insulin resistance, and keeping them on metformin may allow you to actually use less insulin to get them to control. Okay, this Actrophane has now been replaced by Novamix, and this is what you would do. So if your patient was already on a basal insulin, so let's say they were on 20 units, and now you want to change them to a premix, you take that 20 and you say 2/3 of that is, let's say, 14. So they'll take 14 in the morning and 6 before breakfast and 6 before supper. And that's where you would go. You would start, and then you would go from there. If they're not on any insulin and you decide that you want to bypass the basal route and go straight onto a premix, that's fine. Then you just go 0.3 units per kilogram. So if your patient is the 70 kilogram person, so 0.3 of that is what, roughly say 25 units. So they would basically then take, say roughly 15 units or 18 units in the morning and 7 units in the evening. This 2/3, 1/3 is the usual split. Don't be too confused if you read or you see others using a 50-50 split. I'm more a 50-50 person. So when I start my patients on a premix insulin, I split it in 2. Mainly because South Africans, we eat big breakfasts, we eat big suppers. Often lunch isn't a major thing in South Africa. So I like to cover my patients for dinner and for breakfast. But it doesn't matter if you go 2/3, 1/3, and you slowly titrate up, you will eventually get your patient onto the right doses that they need. And this is a rough guide to how one could teach your patient insulin correction doses. So we teach our patients to monitor their glucose before breakfast, to have a look at this, and to adjust their insulin dose according to what their reading is. So they'll either increase it by 2 or 4 units or decrease it by 2 or 4 units, or actually give their usual prescribed dose. Okay, so if we have a look at Mr. X to end, you can see here, he's a young man. He's got a family history of a macrovascular disease. He's showing that he's quite motivated and empowered because he's going to gym, he's compliant on his medication and diet. So in this patient, I think it would have been wise to have chosen an A1C of at least less than 7% as the target. Okay. But then he was left for 6 years, okay, with the lowest the A1C has been is 8.5%. And the result of that is that he now unfortunately has diabetic complications that potentially could have been reversed. And now that he actually has diabetic complications, it's as important now to improve his glycemic control, because that is exactly what the UK PDS trial showed us. It showed us that if your patient has complications, you can delay or even get some to regress by good glycemic control. Okay, so in summary, HbA1c reduction towards an individualized target remains the most important part of managing a person with type 2 diabetes. So I know we don't have access to many of the wonderful drugs that the rest of the world and our private sector has access to, but we do have access to drugs that we can achieve control with. very important that we empower ourselves to become confident with those, and we try and use them as early as possible in our patients with type 2 diabetes to try and get them to their target as soon as possible so that we can delay or at least prevent the onset of complications. We have to, all of us, and we all have it, we have to avoid therapeutic inertia. Please, we must initiate insulin, especially in patients with an HbA1c greater than 10%, and we can do it quite safely within the majority of them, a basal insulin, and then we intensify as needed to a premix insulin or anything else that is as indicated. So thanks very much. Happy to take any questions. There was a slide that I had there with the latest, the insulins and their switches, but I don't know why it's not in the presentation. But I hope you all got the concept that now ActRapid and Protophane is actually being ousted, and we're now getting access to a Pedra that will replace ActRapid and Optisulin that will replace Protophane. There it is, the Optisulin and the Pedra. And then the Novamix will replace the Actrophane. And we shouldn't worry. We should actually be happy for our patients because they are actually much safer insulins. The only thing to remember is Novamix, from Actrophane to Novamix, it's unit for unit. From ActRapid to a Pedra, it's unit for unit. The only thing we have to remember is that when we're converting our patients from Protophane to Optisulin, that we decrease the dose by 20%. So thanks very much, and happy to take any questions.
Thank you very, very much. I think that was one of those key presentations that's going to change practices across the board. And I like that term that you had in terms of inertia, because I think that is one of the challenges that we have when you're not confident, because there's so many implications of putting somebody on insulin that people tend to delay and sort of hope the next doctor will do it. And it's a little bit to encourage wherever you are at to get brave and start on insulin. There might be on the call.
And just to emphasize that it's all of us. All of us are in that situation, and especially in the public sector where our clinics are very busy, and now we have to initiate someone on insulin. You don't have access to a diabetes educator, and it's a big thing. It's time consuming.
So the one question I just have, and I'm hoping some of the DCSTs might help us with that. This is a circular that came out in October of last year. And when it came out, I'll just scroll up. It was saying that they were expecting constraints for 6 to 8 weeks because there was an issue with temporary supply problems. And the worrying sentence for us who are very excited about Optisulin and Novamix is that it was called a temporary update to the EML to assist the provinces in procuring these insulin pens in the absence of human insulin products, but it wasn't sure whether they're going to be available long term. It seems like it's only to the pen set. So I'm just trying to get clarity. Do we now have Optisulin and Apidra as the new replacements for Actrophane? Can we replace all patients who are on Actrophane and ActRapid to Optisulin or Novamix? Or are there provisos? And I don't know, Jenny, I don't know if you know the answer to that question. Or
so if I can just say that last year, remember they... And I have my own ideas of why this happened. But according to the manufacturers, Novo Nordisk, they couldn't supply these insulins that we used to, so the ActRapid and the Protophane and the Actrophane, in pens any longer. And so that when all of us had to convert our patients from pen sets back to needles, syringes and vials. And then the odd people who actually couldn't use the syringes and vials were then allowed to use Optisulin and Apidra pen sets. Now, towards the end of last year, they actually then told us they can't actually even supply the vials any longer. And so that forced all of us here in the Western Cape to start moving over to the Apidra, Optisulin and Novamix. And my understanding now is that is the status quo, that we cannot get access to these Act Rapid and Protophane and Actrophane in the vials or pens. So we're now all having to change our patients to Apidra, Optisulin, and Novamix.
That's a nice,
And
nice
hopefully
problem.
that's going to stay.
Jenny Nash, Jenny is one of our DCSTs here in the Amatola district in the Eastern Cape. Jenny, do you have any updates for us?
Yes, I just wanted to confirm what Prof has been saying, but
Right.
also just to say that I think this is a golden opportunity
Mm.
regarding advocacy to make sure that this stays. Because I think I was just thinking the other day back to the ARV era when we started on individual drugs,
Yeah.
and how those of us who are working in the ARV sort of sector were lobbying for fixed dose combination drugs. And Prof has mentioned the clinical inertia around starting people on insulin. And it's so much easier to start someone if you've got a pen. And so I'd actually drop Prof a message during the week just to say, can we advocate? Is there, the Diabetic Alliance we heard were sort of advocating around these issues. I really think as clinicians, we need to stand up and unite and say we only want pens and pens for everyone, in the country who's diabetic, and obviously the information around how to use it, etc. Because I think that will really help to change the misconceptions, and it's just so much easier to prescribe patients and for patients themselves to understand with the clicking and you're not being able to see if maybe our diabetics are sight impaired as well, and etc. So I think I also not too sure of the long term. We certainly have got quite a good supply now of Optisulin and Apidra and the Novamix. We still also have the vials. I'm not too sure if that's going to continue, but I think we really need to advocate as clinicians that we only want pens and hopefully drive the price down, change manufacturing practices, etc. Thanks.
Brilliant. Thank you, Jenny. I agree. There's also a question here about if there's a maximum dose for the premix insulins. And we do sometimes have this where you get patients where you're putting that insulin up and up and up, and they can end up on quite large dosages. So actually, I'll add a question to that. If you've got somebody who's having 40 or 50 units in the morning and another 36, 30, 40 units in the evening or whatever, do we need to split the dosages? Can you give it all in one go in the same spot? So just some advice on those larger dosages of insulin, especially for our very large patients who sometimes require quite high dosages.
Thanks very much. I just want to say that, I love what Jenny's saying. I mean, it is a moment of opportunity for us to now really advocate and all of us stand together to get, number one, the pen sets, but also, to get much better insulins for our patients. Living with diabetes is very, very difficult. And, in the public sector, it's even that more difficult because they're having to use drugs that are not as predictable and that are not as comfortable as other drugs. They're having to use technology that is quite difficult. So I think Jenny's right. And if you have a look at those prices, the public sector can't complain, to get access to an insulin analog for 39 Rand. That is like $2. In America, these things are costing $300, $400 in the private sector. I'm not sure I think that's probably 39 per pen. But in the private sector, it's 150, 200 Rand or 150 Rand per pen. So we're really getting it much cheaper. And I think we really need to put pressure on the government for our patients to keep it like this. When it comes to the maximum dose, I always use an anecdotal story to illustrate this because we had a patient at Groote Schuur Hospital who had an HbA1c of 8.5%. She was on 180 units of Act Rapid before each meal and 400 units of Protophane at 10 o'clock at night. So if you add it up, that's close to 1,000 units of insulin. And her HbA1c was still 8.5%. Now, she landed up having a mutation in her insulin signaling pathway that gave her very, very severe insulin resistance. And my main point of it being that there's no upper limit. Okay, there's no upper limit to insulin. You start low, you go slow, and you slowly up titrate it till you reach your target, your individualized target. Obviously, at each step, you have to check the compliance of your patient. So, for example, let's say on 180 units of optosulin at night, and my patient's fasting glucose is still 12. I need to really go and have a look, is my patient injecting correctly? Are they keeping their insulin in the correct place? Has it expired? Has it denatured? Do they have lipohypertrophy? Are they injecting into lumps? Are they waking up in the middle of the night and having a midnight snack? So there's a variety of things you have to exclude. But if you've excluded all of those, then you have to go up. And so there's no real upper limit. It does, as you've mentioned, become a problem when you're now having to inject large volumes into an area because let's say, and in each injection, I think the maximum dose in each injection is 60 units. So if you've got a patient on 120 units, they're actually having to give 2 injections unless they keep the needle in that same spot and then wind it up again and inject, which we don't recommend. They're then having to inject in 2 or 3 different areas to get that amount of units in. And so if they are needing, and as you say, we've got many patients who are obese, they're markedly insulin resistant. There are a couple of things that one can try. Obviously, we've mentioned the metformin to try and increase insulin sensitivity so that we can maybe use less insulin. In the private sector, what they have tried, they've tried DPP-4 inhibitors or GLP-1s to get the patient to lose weight so that they can use less insulin. But unfortunately, in the public sector, where we're very limited, we just basically have to go up with our insulin. And whether you convert a optosulin then into a premix, I generally don't go above 60 to 80 units. I like to then change them to a premix to try and see if I can get better control. But there are other doctors that would go up to 150, 200 units of a basal insulin. I think you need to develop something that you're confident with. There's no wrong or right. As long as you do it together with your patient, you're targeting the correct values. I think anything that you decide with your patient and that your patient's willing to do will basically be fine.
Thank you very, very much. I think it's those little tips always that make such a difference, when you've got the patient sitting in front of you. And then, I think it's this, we have all these hesitations, which ends up meaning that we've got lots of patients that are not controlled. And actually, one of my registrars here in family medicine, he's actually doing his M.Med, and he's going to particularly looking at the knowledge, attitudes, and behaviors of patients, or those patient factors that you mentioned in terms of insulin. So we're going to get some local Eastern Cape data to see what's also happening with our patients. And quite often the patients, as you quite not so keen to go onto insulin. The one thing I add is really
that'll be great.
Counseling our patients very early that they will probably eventually end up on insulin. Because sometimes patients feel like when they're ending up on insulin that somehow failed or they haven't done enough or they've done something wrong. Being able to say to patients, this is a progressive disease, insulin's amazing stuff. We can get away with orals for a bit, but eventually we will end up on insulin. Don't worry, it's not so bad. But it's a little bit that preparation so that by the time you're having the decision to go onto insulin, the patient is already prepared. And I think that's important from the beginning when we start our patients on treatment.
I agree with you 100%. And sometimes you can use that as a motivation factor to get them to adhere to things. Saying basically, look, you can delay insulin by losing weight, sticking to good lifestyle measures, taking your medication. And that is, in fact, true. You can delay the progression of type 2 diabetes. So you can use it for motivation. And then there was something else that I wanted to say, but I've now forgotten. Sorry, I've forgotten. But yes, I mean, Very important to gain the confidence of your patient and to start early, that they understand the path that's ahead of them.
Right. Thank you very, very much. We've done very well with time as well. There's no more questions in the chat or hands, so I think we can close off the evening. It'll be lovely to have some possible future talks as well. We've got talks through the year as well from endocrinology. I'm thinking of things like thyroid, for example, as well.
Sure.
So we very well would love to invite you again in the future. And I was also very interested in your interest in that crossover between our endocrinology and our infectious diseases. So very helpful to start getting some adult medicine talks into our program. Thank you very much, everybody. Next week, I'm going to have a blank. I know the week after we're doing polytrauma. It'll come back to me. We will send you notification of what awesome talk is going to happen next week. And then we will have polytrauma after that, which we're also looking forward to. And then in our third week of March, we're going to have a talk from one of the top hand surgeons in the country on an approach to hand injuries. And then we'll have an ethics talk for our last talk at the end of the month. Everybody have a lovely evening, and we will see you all next week. Thank you very much, Prof. This has been a very informative talk.
Pleasure. Thank you very much. Good night, everyone.
Poll. I'm just putting the poll out. Please fill in my poll. Ooh, otherwise there we go. Please do fill in the poll before you go off. Thank you very much.
Yeah. Thanks. Bye-bye.